Today I am going to tell you something about our longest bone in the body, that is the femur. Like long bone, it is having upper end, lower end and shaft. Upper end, it is having three parts, main: head, neck and trochanters. Greater trochanter, lesser trochanter. The shaft, lower end, two condyles, lateral condyle, medial condyle and epicondyles. Step by step we will discuss. So first, upper end, head, neck, greater trochanter, lesser trochanter. Neck is not the part of the epiphysis. Once we study the ossification, we will see the secondary centers. There appear for one for head, one for greater trochanter, one for lesser trochanter. But for neck, actually it is not the part of the epiphysis, it is a continuation of the aphysis. Okay? So head, maximum part is articular, whereas the center we are getting a depression, fovea or pit, for the attachment of ligamentum teres femoris. So it will be there, it will attach to the center of the acetabulum, the ligamentum teres hepatis is getting attached. So now the upper part, head, neck and this greater trochanter, lesser trochanter, you can see these markings here. So here the attachment of this capsular ligament, and posterior part of the neck you can get a faint depression for the attachment of obturator in externs. Now in between this two trochanter there is a line, that is intertrochanteric line, which is separating the neck and the shaft, and posteriorly you will see in between these two trochanter there is a crest that is called intratrochanteric crest. So greater trochanter is having anterior surface, lateral surface, medial surface and posterior border and superior border. So if you see here, we have already studied the muscles of the gluteal surface of the ilium. Here we are getting the gluteus minimus. So we know the three gluteal lines are there: posterior gluteal line, anterior gluteal line and inferior gluteal line. So in between the anterior gluteal line and inferior gluteal line, so there is the gluteus minimus. Here the anterior and the posterior, that is the gluteus medius, and behind the posterior gluteal line, that is the gluteus maximus. So from this part the muscle is coming here to the anterior surface of this greater trochanter, that is the gluteus minimus. So in the lateral surface of the greater trochanter, gluteus medius is getting attached in oblique fashion, and anteriorly and posteriorly two bursas are there, the trochanteric bursa, which is covered by the gluteus maximus. Now coming to the intertrochanteric line. The intertrochanteric line here mainly two muscles and two ligaments are there. Two ligaments, one is capsular ligament and another is the toughest ligament in the body, is the iliofemoral ligament. It's coming like this, iliofemoral ligament. Okay. Now two muscles are there like this way. One is the right side, lateral side, that is the vastus lateralis, and this side, medial side, vastus medialis. Posteriorly we are getting, this is the intratrochanteric crest. So intratrochanteric crest, in the middle of the intratrochanteric crest we are getting a tubercle, that is called So where the name itself is studying quadratus femoris. So this part of the, so this is the obturator foramen. You have seen where the obturator external muscles is coming, and behind this obturator externus, this area we are getting the attachment of quadratus femoris, which is from here, which is getting attached to this quadrant. The medial surface of this, if we see, this was head, neck, greater trochanter, lesser trochanter, intertrochanteric line, and posteriorly the intertrochanteric crest. So this is the greater trochanter, outer surface, lateral surface, posterior border, superior border, and this is the fossa that is in the medial surface, where we are getting the muscle that is obturator externus. Okay, so obturator externus, this is the obturator foramen here. So from where obturator externus is coming like this way and taking a turn and attached to this trochanteric fossa. Now coming to the superior part of this greater trochanter. So superior part, like this way, if you see the superior part, greater trochanter, where from anterior to posterior, 4 muscles are there: gamellae superior, obturator internus, gamellae inferior, and piriformis. So if you see these muscles, once we study the structures passing through this greater sciatic foramen, structure passing through lesser sciatic foramen, this lesser sciatic, this is the ischial spine. So, and the inside, we have just now we have seen this is the origin of obturator externus. The same way from inside, this will be obturator internus. So from there, muscles is coming out like this way, and here we will get the 2 gamellae. The 2 gamellae with obturator internus is coming like this way and inserting on the upper border of the greater trochanter. And from here, once you study the sacrum, you will see from inside. So the piriformis muscle, which is actually dividing the greater sciatic foramen to upper part and lower part, this piriformis is coming from here and going to the posterior part of this upper part of the greater trochanter. So all these 4 muscles, piriformis and gamellae, 2 gamellae with obturator internus, they are all coming and attached to the upper border of the greater trochanter from anterior to posterior, gamellae superior, obturator internus, gamellae inferior, piriformis. And the middle part we are getting obturator externus, and here in the posteriorly intertrochanteric crest we are getting the quadratus femoris at the quadrate tubercle. Quadratus femoris at the quadrate tubercle. Now see, so this is the greater trochanter, this is lesser trochanter. We have seen anteriorly head, neck, greater trochanter, lesser trochanter. So if you see from posteriorly head, neck, greater trochanter, lesser trochanter. In the lesser trochanter, you will see the attachment of iliopsoas. So how it is coming? We have already seen this is the anticipital spine, this is tubercle, so this is the inguinal ligament. So iliacus and from here psoas, they are coming, becoming iliopsoas below the inguinal ligament. So we have seen they are forming the floor of the femoral triangle. They are coming here and ultimately they are joining to the. So that's why they are helping in the flexion of the hip joint, iliopsoas attached to the. So these are the all structures we have just now seen in the upper part of the femur. Now coming to the shaft. So shaft, it is not. Now in the shaft, we'll see it is having anterior surface, lateral surface, medial surface. So automatically lateral border, medial border. There is no anterior border. Anterior surface, here the lateral border, so lateral surface, the medial border, then medial surface, and posteriorly posterior border. Very interesting thing, this posterior border is not a single border. This middle third of the posterior border is called linea aspera. We have to discuss elaborately what is linea aspera. This is not a single border. Here all the three intermuscular septums, how they are placed with all the different muscles, we'll discuss slowly. And linea aspera, when is going up, it is diverging both sides and making a space here. So that is the part, is the posterior surface above, and same way linea aspera is diverging below. That is another space that is called popliteal surface. So if we see the surfaces, femur is having anterior surface, whole anteriorly, then lateral surface, medial surface, and posteriorly upper one posterior surface, and inferiorly we are getting the popliteal surface. Actually, this lateral border and medial border, they are not very prominent, they are roundish, but we will see all the intermuscular septum there, the medial intermuscular septum, lateral intermuscular septum, and posterior intermuscular septum, they are all connected here at this linea aspera. And the medial intermuscular septum is attached above this line. Medial intermuscular septum also attached to the lower. This is medial side, so medial supracondylar line, lateral supracondylar line, where the lateral intermuscular septum attached, medial supracondylar line with the medial intermuscular septum attached. So now coming to the posterior upper surface, we have seen this linea aspera gone up and diverged medially. So this is called spiral line. So we have seen this is intertrochanteric line. It is coming medially and taking a turn, becoming the spiral line. This posterior surface, the lateral part, lateral line, we are getting in ridge area. So that is the gluteal tuberosity, where the gluteus maximus muscle is attached. So if you see here, so this is the area where the gluteus maximus is coming. So gluteus maximus is coming like this way. You can see this is the intertrochanteric crest, where the quadratubercle, quadratus femoris is there, and this part. So this is linea aspera. It is diverged up. So this part where the gluteal tuberosity will be there. So gluteus maximus is coming and covering all these muscles and getting attached here to the gluteal tuberosity, where the gluteus maximus is getting attached, covering and making the major muscle of the buttock. Okay, so this is the gluteal tuberosity here. So where the gluteus maximus, so gluteus maximus is here. Here is gluteus medius, and anterior part of this greater trochanter, we are getting the gluteus minimus. Gluteus minimus, gluteus medius, and here the gluteal tubercle, we are getting the gluteus maximus. Intertrochanteric crest, where the quadratubercle, we are getting quadratus femoris from here, quadratus femoris, and medial part of the greater trochanter, we are getting the trochanteric fossa, where the obturator externus is coming. From internus, in inner side, we are getting the obturator internus with these two gamellae. We see here the two gamellae and obturator internus. They are coming to the superior part of this greater trochanter with the piriformis. So from anterior to posterior, gamellae superior, obturator internus, gamellae inferior, and piriformis. Okay. Now coming to this linea aspera, upper part we just now discussed. So if you see this is the anterior part, posteriorly you can see this linea aspera. Middle 1/3 part is called the linea aspera, separately I will discuss. So upper part we are getting laterally the gluteus maximus, the gluteal tuberosity. Medially we are getting the attachment of the pectineus, arrector brevis. Okay, because they are all in the arrector part. Basically, see. So from here we have seen this was the inguinal ligament, this is the femoral triangle. We have seen how these adductor muscles are coming, this is the adductor compartment. Okay, so where this pubis, the body, superior ramus, inferior ramus, where the adductor, the longest, then we are getting adductor brevis, and lower part we are getting the adductor magnus. and here pectineal line will get the pectineus. So these are the muscles, they are forming the floor of the femoral triangle. Now coming to this part, linea aspera, where the 3 intermuscular septum, this is medial part, this is lateral part, because I am seeing from behind, this is lateral part. So here we will get the iliotibial tract, so facial lata. From there 3 intermuscular septum are coming, lateral intermuscular septum, posterior intermuscular septum and medial intermuscular septum. Out of this, thickest is the lateral intermuscular septum, posterior is very, very faint. So in between these 3 intermuscular septum, we are getting 3 compartments. Here is the anterior compartment, this posterior compartment and medial compartment. Okay, so we have seen, if you see from anterior, this is the anterior surface. Just now I told you this is intertrochanteric line, medial intertrochanteric line, 2 muscles, 2 ligaments above, capsular ligament and iliofemoral ligament, toughest ligament, iliofemoral ligament like this. Okay, and 2 muscles down, one is laterally vastus lateralis, one is vastus medialis, and this whole anterior part we are getting the vastus intermedialis. So these 3 vasti with the rectus, you know, this is anterior inferior iliac spine, where you are getting the straight head, and below this inferior line we are getting the oblique head of rectus. So they are coming like this way, and all these muscles they are joining at the patella. So we are getting this quadriceps femoris, and here we are getting quadratus femoris. This is quadratus femoris, and here we are getting quadriceps, because 4 heads, vastus medialis, lateralis, vastus medialis, vastus intermedialis and the rectus. Okay, so the anterior surface, huge, already I have shown you in the dissection, the huge vastus intermedialis, but origin of the vastus lateralis and medialis, they are not taking this much space like vastus intermedialis, and the lower 1/3 below the vastus intermedialis we are getting the origin of articularis genu and the space for suprapatellar bursa. Now coming to the posterior, again to the linea aspera, is very, very important. In the exam many times they used to ask, tell me the structures which are there in the linea aspera from medial to lateral or from lateral to medial. So I forgot to tell you what is the anatomical position and side determination of the femur. For anatomical position, if you just keep the femur, it is not straight. If you hold the femur with your index finger, keeping it just below the head, you can see this direction. Actually, this is the anatomical position. Or if you can put the condyles of the femur on a table, straight table, you will see this angulation is coming. So that is actually called this Q angle, because all the quadratus, they are coming like this way. You are looking straight. This is also called Q angle. Q angle, around about 15 to 20 degree is the Q angle. So that is the angulation of this shaft of the femur with the vertical line. So that is the Q angle. So normally femur is not straight, it is angulated. So that's why to keep the condyles on the table, you can get the actual anatomical position, or you can hold the femur with the index finger. Now coming to the side determination, head will be always medially, then anterior surface is smooth, you can see posteriorly linea aspera you will see. Okay, and this is the 2 point, immediately you can tell whether it is right sided or left sided. If you hold it like this way, there the linea aspera should not be anterior. So if linea aspera is posterior, head is medially, it has to be right sided. If it is left side, see, if it is left side, the linea aspera is coming anterior, so that means it is wrong. It has to be like this, where linea aspera posterior, anteriorly, smooth surface, head medially. And normally head is medially, little upward and anterior. So that is the direction of the anatomical position. So, and this neck and the shaft is also having an angle. Normally it is called neck shaft angle. In children it is almost 160 degree, whereas in adult round about 125 degree. And another angle is there, the angle of torsion. So that is we can now see this is the plane of the neck and shaft. Whereas if we see from top, so we will see the neck and the shaft, that is also having a plane, and two condyles, they are also having a plane. If you see the plane, this is the plane of the condyle. Okay, so that condyle plane is not same with the plane of this neck shaft. So this plane and this plane not in the same. So there some torsion is there. So that is called torsion of the femur. So this angle of this neck shaft and angle of this condyles, they are having a like this way. This is the angle of the neck shaft angle, and this is, if we see from top, so this is the angle. So this angle is round about 7 to 12 degree, where this angle and this angle, so here condyle, they are little bit rotated, so that's why their angle is not same with this, because we know the lower limb is rotated medially, that's why it is also got little medial rotated. So this angulation is called angle of torsion. Okay, so what I was telling now, the linea aspera here, so this is medial, this is lateral, I am seeing from posterior. So here we are getting three lines where the three intermuscular septums are joined and how the muscles are there. We have just now seen the intertrochanteric line, where laterally the vertilateris, vertimedialis, is a huge attachment, straight attachment in the lateral surface, whereas medial surface, the huge attachment of this vastus medialis. But the whole anterior surface, upper two-thirds, the attachment of vastus intermedialis. So when we see the linea aspera, laterally first muscle is the vastus lateralis, then lateral intermuscular septum, then coming laterally, so lateral intermuscular septum and posterior intermuscular septum, there is a muscle in between, small muscle there, the short head of biceps. Okay, so here also short head of biceps, then posterior intermuscular septum, then we are getting adductor magnus, then upper part we are getting adductor brevis, lower part adductor longus, then we are getting medial intermuscular septum and vastus medialis. So if we see from medial to lateral, vastus medialis, then medial intermuscular septum, then upper part adductor brevis, adductor longus, lower part, then we are getting huge attachment of adductor magnus, then posterior intermuscular septum, then lower part we are getting the short head of biceps, then lateral intermuscular septum we are getting vastus lateralis. So these are the sequence, you have to tell always in sequence all the muscles. Now coming to the lower part. Okay, in the lower part, so we are seeing these are the two condyles, medial condyle and lateral condyle, intercondylar fossa, and here is the articular surface for the tibial surface and patellar surface. There, this supracondylar line is the medial side, so medial supracondylar line, lateral side, lateral supracondylar line, and here is another space we are getting, there is a popliteal space. So where the popliteal fossa, floor of the popliteal fossa, we will see how the artery, the femoral artery will be there very close to this bony surface, because from the adductor canal we have seen here femoral triangle, adductor canal is going behind, in between the hiatus of the adductor magnus and reaching there in the popliteal surface. So the medial surface, the artery is coming like this way and going to posteriorly. So there will be a hiatus here where the huge attachment of the adductor magnus up to this adductor tubercle. You can see here adductor tubercle. So adductor magnus is a composite muscle. It is supplied by both adductor compartment of pituitary nerve and the sciatic compartment, posterior compartment by sciatic nerve. So here it is the adductor tubercle. This part is very, very important. 3 points are there for adductor tubercle. First point is very bony prominent, so surface marking you can feel. Second point here is the attachment of the ischial part of this aorta magnus, and through this the epiphyseal line goes, because ossification wise this lower end ossification, lower secondary center comes before birth. The medical importance is there. So by 9 months usually epiphyseal centers, secondary centers, they appear after birth. This is the first epiphyseal, this is the first secondary center which is appearing before birth. So that's why it is having medical importance. So this is the aortic tubercle. So where the whole aorta magnus is attached from here to the posterior, in the posterior compartment, where it is giving a gap here for allowing the femoral artery and vein come to the popliteal fossa. So we can see here the medial supracondylar line, where the medial intermuscular septum is attached, lateral supracondylar line, where the lateral intermuscular septum is attached. So at the lower part we will get the attachment of the medial head of gastrocnemius, because these two muscles, they will come below. You can see our cuff muscles, so medial head and lateral head of gastrocnemius. This is the medial head will be arising here, and here upper part will get the muscle plantaris. Immediately, just like medial head of gastrocnemius, lateral is coming a little lower, but they are all extracapsular. So here we will get another small muscle, that is a plantaris. Okay, in the lateral supracondylar line we will get the attachment of plantaris. Then below we will get the attachment of lateral head of gastrocnemius. Here we can see the articular surface. The lower part is the tibial articular surface, and here is a V-shaped. You can see this V-shape. So this V-shaped, so that is for the patellar surface, patellar articular surface. Just this articular surface above 1 centimeter above, we will get the capsular lining, and in the lateral part we will get depression here, where the attachment of popliteus, it is intracapsular popliteus muscle. Okay, now in between these two condyle we are getting, this is the intercondylar fossa. Okay, another point is the most medial part, the most lateral part of the condyle, you will get the epicondyles, where medially the tibial collateral ligament, laterally we will get the fibula collateral ligament. We can discuss it more details when we study the knee joint. Only one point I will say here, this is the intercondylar fossa, where we will get the two cruciate ligaments, the anterocruciate ligament and posterior cruciate ligament. Two cruciate ligaments, anterocruciate ligament and posterior cruciate ligament. Basically the name anterior and posterior as per the attachment below. So anterior cruciate ligament from posterior, it is coming to the anterior part of the tibia. You will see there when you study detail about the knee joint. And the posterior cruciate ligament, it is coming from the anterior part of this medial part. So this is the medial part, we will get the attachment of the posterior cruciate ligament, where the lateral part posteriorly we will get the attachment of the anterior cruciate ligament. From there it is going anteriorly, and here from anterior part is going posteriorly. Okay, this much you know now for the time being. In the intercondylar fossa we are getting these two ligaments, anterior and posterior cruciate ligament, very very important ligament inside the joint, connecting the tibia and the femur inside the joint. Okay, strengthening the joint more. So this is all about your femur. I think it's enough. Another point very important, this line, if you see the shaft is little bit convex anteriorly, that bending. So as the femur is the longest bone, it is taking so much weight during standing, so there will be chance of breakage. So for that, this linea aspera, it is actually the buttress, okay, through which the most toughest part area. Okay, once you cut the femur, you can see another lecture. Inside you can see the different lamellas are there, compressive lamella, tensile lamella and calcar femori. So that is going through this linea aspera. This is the thick part of the bone. So buttress of the femur, the same way for the pelvis also buttress, because when you are standing, the weight transmission is going to the spine, sacroiliac joint, then it is going through the hip joint, and when you're sitting, the transmission is going through the ischial tuberosity. That's why this area is very, very thick in this hip bone that is carrying maximum weight. That is the buttress line is there. In the same way, here also linea aspera, where the line of buttress is there. Regarding ossification, already I told you the upper end, lower end shaft, where you will get the primary center here, upper end 3 secondary centers, one for head, one for greater trochanter, one for lesser trochanter, whereas one secondary center for lower end. They usually appear after birth and they ossify by at the age of 20-25, whereas primary center arises at about 7 to 8 weeks of intrauterine life, where we get the nutrient foramen. We know the direction of the nutrient foramen. Here it will be away from the knee joint, so that's why the knee part, this part, is the growing end. So I think this is all about femur. If you have any other queries, you go to the book to know more detail and you can discuss with me. Thank you.